now going to introduce Associate Professor Daniel Moon, a urologist at Peter MacCallum Cancer Centre, who's going to be talking about will PSMA PET CT replace mpMRI for the diagnosis of prostate cancer. Thanks very much, Dan.
Thanks, Louise, and thanks all the organisers for the opportunity to present. It's a real honour to be involved in this inaugural conference. I don't really want this to be a competition between nuclear medicine physicians and MR radiologists as to who has the best kit here, despite the topic of the talk I've given. I want to focus on the bigger picture, and that, of course, is how do we prevent men from dying of prostate cancer and do the least harm in the process? And it turns out that PET has a big role to play in this. We've come a long way in a short period of time. Back not that long ago when we were starting practice, a man would present with a high PSA and would literally be offered a stab in the dark, which is a transrectal ultrasound-guided biopsy. Sometimes we hit the tumour, sometimes we wouldn't. And for those men who went to surgery, the discrepancy between what we found in the final specimen and what the biopsy predicted is often enormous. It's a very unsophisticated way to conduct a screening process. And it gave PSA a bad name. The first half of the PSA era, as you would know, is dominated by debate about whether we're doing more harm than good. And it forced us all to do a lot of soul searching and ways to do better. And of course, the perfect diagnostic algorithm we need is a way to accurately find cancer when it's curable, to avoid the diagnosis of insignificant cancer we don't need to know about, and also in men who have high PSAs or potential risk factors but don't have cancer, avoid biopsying them at all. And the first big step in achieving this was the development of multiparametric MRI. And the Precision trial and others, for the first time, showed a way that we could see the cancer, find it, biopsy it, more accurately characterise it to then guide men as to the best way to manage it. But of course, it's not perfect. It doesn't pick up all cancers. You miss up to 1 in 5 significant cancers in men, depending on the trials or you read, but that's certainly my experience. Doesn't find all cancers. There's a lot of men that are still falsely reassured, a lot of men that are unnecessarily biopsied. And because of this, you still need to do template biopsies, and we still find more cancer than we need to find. So the diagnosis of insignificant disease remains a problem. And furthermore, we're in an age group where pacemakers and metallic implants are not that uncommon, and not all men can have an MRI. So in the same time period, the team at Peter Mac were amongst some of the first in the world to do groundbreaking research showing that PSMA PET scan is really becoming the gold standard for staging prostate cancer. And secondary analysis of trials such as the Pro-PSMA trial made us realise that not only is it very good at finding cancer outside the prostate, but it turns out it's pretty good at finding the cancer within the prostate itself. Such as in this patient. This is a patient of mine. As it turns out, 59, he'd had a negative MRI, he'd had 1 biopsy that was negative, the PSA was still going up, and in desperation I get a PET scan, and lo and behold, this lights up in the prostate. He proceeded to biopsy, targeted biopsy, treatment, and he has a Gleason grade group 3 cancer, now an undetectable PSA. Which led us, these sort of experiences and observations, led to the primary trial, which was just recently published, and congratulations so much to Louise and team for being awarded the best scientific paper with European Urology just last week. That's an immense effort, and it's an honour to be a collaborative part of this team. But this is really a groundbreaking trial. And all we did was throw in a PET scan in that diagnostic algorithm. So men with a risk of prostate cancer, a high PSA, and who'd had an MRI, whether it was negative or positive. We put in a PET scan in that process as well before a biopsy, just to see how it performed. And in around 300 men, we found that the PET scan, the negative predictive value and the sensitivity was a little higher in PET, not that dissimilar to MRI, but you put them together and we have, for the first time, a 97% sensitivity in detecting prostate cancer. It's pre-biopsy, which is really a groundbreaking achievement. And as other people have also found, it also gave you some qualitative analysis. The SUV seemed to correlate with the aggressiveness of the tumour. So you not only find it, stage it, but also characterise it. All this without having to yet do a biopsy. So this is very interesting and also hypothesis generating. It would seem when you look at that primary data, there's a significant number of men that if they were PET and MRI negative, you got up 97% reassurance that you could avoid a biopsy at all. You could target biopsies more effectively, knowing that we're very unlikely to have missed the tumour on this sort of combined imaging. And at the other side of the spectrum, in this group of men, if you had a PIRADS 4-5 and an SUV over 9, or any MRI and an SUV over 12, every single person had cancer. So we can now diagnose prior to biopsy with really great certainty. And so that's led to the launch of Primary 2, which has just opened. And so we're taking this exact group. It's the conundrum of men who have an MRI that's negative or equivocal, but there's still something's not right. The PSA is going up with another risk factor, and we think there still is a chance they have cancer. And in these men, we randomise them. They either have the standard of care, which is the template biopsy, or we perform a PET scan. If the PET's negative, based on our primary data, we can reassure those men they don't need a biopsy at all. If it's positive, we can just limit the biopsy to a targeted biopsy of that area, knowing that we're highly unlikely to miss any significant cancer. And at the end of it all, we expect in a non-inferiority design that we will find the same number of significant cancer, but have de-escalated the number of biopsies and the number of men who've needed biopsies, and furthermore have reduced the detection rate of insignificant Gleason low-grade, low-volume prostate cancer. It's a very exciting trial, and it's going to launch. We've got in Melbourne, Sydney, and it will be around the country in different centres as time goes by. As has already been well touched upon, when we bring PET scanning into play like this, though, with scans cropping up all over Melbourne, all over the world, they're done to different standards, different techniques, and this has been well spoken about already. Tom spoke about it as well. The confounding aspects in performing and interpreting PET scanning is the technical aspects of the tracer, the scanner, the quality control of the chemicals, the image acquisition time, and also from a radiological point of view, what's positive, because we're doing this as we go. In primary, Louise had to work out what SUV we were going to call positive based on the sensitivity and specificity of the data that we had to date. And so the definition of positive is a really interesting question. Now we're talking about prostate because what's come out of the primary trial is this publication, where it's not only just an SUV cutoff, but with a standardised technique, scan, a chemical, you can now use the mapping of intraprostatic patterns of uptake to more accurately call something suspicious or cancerous and apply a score much as you would a PIRADS score. And so this primary score can score lesions as being, even if there's some uptake, mild, moderate uptake, the patterns can help guide you as to whether that's likely to be physiological, benign or suspicious. So they range from these lower scores, 1 to 2, where you have centralised or symmetric uptake within the prostate, and most likely benign, to these more suspicious areas where you have clearly far more avid and focal uptake that are more likely to be suspicious. And when you apply this primary score to that cohort of men, not only did this score correlate very well with the chance of there being significant cancer, but when you compared it with MRI, it actually outperformed the PIRADS scoring in that group of men. So we're well on the way to developing good, standardised, reproducible methods to use PET scanning in this setting. So, in conclusion, it's quite clear that PET scanning is a very good tool to both diagnose and stage prostate cancer, and it does outperform MRI in a number of analyses. However, the combination is the most powerful imaging combination we've had to date to really refine the assessment of men who have a high PSA and can be confidently diagnosed as negative or positive just on imaging alone. But we still need to be working harder and harder on standardising the tracer technique, interpretation and reporting to make sure that we're providing as accurate an assessment and reproducible and consistent an assessment as possible. Thanks very much.